This is the 7th in our series of short videos demonstrating the key components of the care protocol used in the Gastroschisis Interventional Study in Ghana, Zambia, Malawi and Tanzania. This video is focused on removal of the preformed silo and closure of the defect. You need to prepare for the procedure, get the baby on the radiant heater, gather your team, someone to do the procedure, someone to assist and someone to soothe the baby throughout the procedure, either with dextrose or breast milk on a finger to suck or on gauze. You want to do a full ABCDE assessment and correct any vital signs that are abnormal. Fully aspirate on the nasogastric tube to decompress the stomach. You can also do another saline enema to decompress from below. You want to make sure that the bowel itself has been fully reduced and flat within the abdomen without any little mound for 24 hours prior to the procedure to optimise your chances of closure and reduce the risk of reherniation afterwards. Before doing the procedure, you want to fully clean the abdominal wall and cord with an antiseptic solution and dry it thoroughly so that the dressing can stick. Then get your sterile gloves on. You're going to wrap this string around the fingers of your left hand, whether you're left or right-handed, and then as you see the green ring coming up, you're going to push your fingers underneath to make sure that the bowel does not come out. And this is very important because if the bowel comes out again and you have to reapply the silo, it's a very high chance of mortality in the lower resource setting. So I've got the bowel in there. Again, I will dry. I'm going to pull the cord across. Now, if the baby is septic or requiring oxygen or premature, I will just lay the cord gently across the defect so that I don't increase the intra-abdominal pressure at all, which can cause decompensation. But if the baby is well, I can pull the cord across and oppose the two edges of the defect. But I want to keep my fingers there the whole time to make sure that the bowel doesn't come back out again. I'm going to place steri strips, or if you haven't got steri strips, you can use clean new roll of strong adhesive tape. I'm going to place them on the top and the bottom like that. Then you get 12 by 10 centimeter tegaderm dressing. I've cut it using sterile scissors to the center. I'll place one in one direction, flip up the cord and place another in the other direction. Obviously in real life I would remove the back so that it sticks down and that dressing would stay for 10 days. The cord would dry up and it would heal. Now if you have not opposed the two edges of the defect, then you want to keep the cord underneath the dressing so that it can help keep the bowel inside and act as a natural dressing in that area. So I'm then going to apply strips from top to bottom as well over the cord, so the cord is keeping the bowel inside. The whole time I'm keeping my fingers centrally to prevent any bowel reherniation. I'm then going to get a square of sterile gauze and put that centrally, which will help soak up any fluid that leaks from the abdomen and also helps provide a little bit of pressure in that area to prevent bowel reherniation. I'm going to get a 10 by 12 centimeter tegaderm dressing and apply that across the whole abdomen, making sure it is stuck down very well. If at any stage it's not sticking, you dry again and you might need to use a new dressing, or you can reinforce the edges using a smaller section of tegaderm dressing. So sticking down, you may want to cut off these protruding edges of steri strip and or cover with another small tegaderm at the edge there. Key is to keep this dressing in place for 10 days without removing it, even if it starts to look messy under the dressing, because if you remove it before 10 days you can get re-herniation of the bowel. Okay, so I would maybe need another one of those little dressings as well in this situation to keep the dressing completely covered all the way around. I'd need another little one here.